Make the patient comfortable in the supine position with the pillow under the head. To expose the abdomen, place the drape or sheet at the level of the symphysis pubis. Then raise the gown to below the nipple line. Warm your hands and stethoscope. To warm your hands, rub them together or place them under the hot water. From the right side of the bed, inspect the surface, contour and movement of the abdomen. Watch for any bulges or peristalsis. Try to sit or bend down so that you can view the abdomen tangentially. Inspect for the temperature, color, scars, dilated veins or any rashes. And for the contour of the abdomen, peristalsis and pulsations. Now, auscultate the abdomen before performing percussion or palpation maneuvers, which may alter the characteristics of the bowel sounds. Place the diaphragm of your stethoscope gently on the abdomen. Listen for bowel sounds and note their frequency and character. The patient has hypertension. Auscultate the epigastrium and in upper quadrant of bruits. Auscultate for bruits over the aorta, the iliac arteries and the femoral arteries. Auscultate over the liver and spleen for friction rubs. Now the percussion. Percussion helps you to assess the amount and distribution of gases in the abdomen, viscera and masses that are solid or fluid filled and the size of the liver and spleen. Now the palpation. Coming to the light palpation, gentle palpation aids detection of abdominal tender muscles, muscle resistance and some superficial organs and masses. Keep your hand and forearm on a horizontal plane with fingers together and the flat on the abdominal wall. Palpate the abdomen with a light, gentle dipping motion. As you move your hand to different quadrants, raise it just off the skin, gliding smoothly. Palpate in all the 4 quadrants. Now the deep palpation. Deep palpation is usually required to delineate the liver edge, the kidneys and the abdominal masses. Again, using the palmar surface of your fingers, press down in all 4 quadrants. Identify any masses. Note their location, size, shape, consistency, tenderness, palpations, and any mobility with respiration or pressure from the examining hand. The rib cage shelters most of the liver. Direct assessment is limited. Coming to the percussion first. Starting at the level well below the umbilicus in the right lower quadrant. Percuss upward, downward towards the liver. Identify the lower border of dullness in the mid-clavicular line. Next, identify the upper border of the liver dullness starting at the nipple line. Percuss downward in the mid-clavicular line until the lung resonance shifts to the liver dullness. Now the palpation. Start palpation too close to the right costal margin, risk missing the lower edge of an enlarged liver that extends into the right lower quadrant. Ask the patient to take a deep breath. Try to feel the liver edge as it slides down to meet your fingertips. When palpable, the normal liver edge is soft, sharp, and regular with a smooth surface. If you feel the edge, slightly lighten the pressure of your palpating hand so that the liver can slip under your finger pads and you can feel its anterior surface. Another method is the hooking technique. The hooking technique may be helpful especially when the patient is obese. Stand to the right of the patient's chest. Place both hands side by side on the anterior abdomen below the border of the liver dullness. Press in with your fingers and upward the costal margin. Ask the patient to take a deep breath. Place your left hand flat on the lower right rib cage and gently strike your hand with the ulnar surface of your right fist. Ask the patient to compare the sensations with the produced by a similar strike on the left side. Coming to the percussion, two techniques may be helpful to detect the splenomegaly, that is, the enlarged spleen. Percuss the left lower anterior chest wall roughly from the border of the cardiac dullness at the sixth rib to the anterior axillary line and down to the costal margin, an area termed as the obese space. Then check for an splenic percussion sign. Percuss the lowest interspace in the left anterior axillary line. This area is usually tympanic. Then ask the patient to take a deep breath and percuss again. When spleen size is normal, the percussion note usually remains tympanic. If either or both of these tests is positive, pay extra attention to palpation of the spleen. Palpation. To enhance the relaxation of the abdominal wall, the patient should keep arms at the sides and, if needed, flex the neck and the legs. With your left hand, reach over and around the patient to support and press forward the lower left rib cage and adjacent soft tissues. With your right hand below the left costal margin, press inward the spleen. Try to feel the tip or edge of the spleen as it comes down to meet your fingertips. With the patient lying on the right side with legs somewhat flexed at the hips and the knees. The kidneys are the retroperitoneal and usually not palpable, but learning the techniques of examination help you distinguish enlarged kidneys from other organs and abdominal masses. Coming to the palpation, move to the patient left side. Place your right hand behind the patient just below and parallel to the 12th rib, with your fingertips just reaching the CVA. Lift trying to displace the kidney anteriorly. Place your left hand gently in the lower upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press your left hand firmly and deeply in the left upper quadrant, just below the costal margin. Try to capture the kidney between your hands. Ask the patient to breathe out and then to stop breathing briefly. Slowly release the pressure of your left hand, feeling at the same time for the kidney to slide back into its expiratory position. If the kidney is palpable, describe its size, contour, and any tenderness. A normal right kidney may be palpable, especially when the patient is thin and the abdominal muscles are relaxed. To capture the right kidney, return to the patient's right side. Use your left hand to lift up from the back and your right hand to feel deep into the right upper quadrant. Pressure from your fingertips may be enough to elect the tenderness. If not, use fist percussion. Place the ball of one hand in the CVA and strike it with the ulnar surface of your fist. Use enough force to cause a perceptible but painless jar.